Hello, everybody. I normally start with good evening, but we're starting to get a lot more US speakers on. So hi, everyone. Thank you very much again for tuning in. You're stuck with me tonight. My name is Simon Ramshaw. Some of you may know me. I'm the managing director of Erchonia over in Europe, the Middle East, and Africa. Work very closely with the US mothership, should we say, in delivering these our laser technology into the EMEA market. I would like to introduce you firstly, for anybody who didn't come on last week, to Dr. Satya Sardonicus. Hi, Dr. Satya, nice to see you again.
Nice to see you as well, Simon.
Good. Yeah, this is part two of Dr. Satya's first lecture that she did last week. So I'm imagining we probably have the same people on. So I'm not going to dwell too much on Dr. Satya's background, but for those who didn't actually click on last week, she's getting a great reputation in the US, and she's gladly offered her services over to us in Europe. She's a strategic healing consultant and coach, and she's a founder of Resilience Artist, where she specializes in unsolvable complex cases involving sensory processing distortion, chronic stress, and unsolved trauma. So even from that title alone, I think it opens up a lot of questions, from us about Dr. Satya's experience and to test her for her knowledge. But before we go on to that, I just, for the benefit of those who don't know us very well, I just wanted to cover who Erchonia are very quickly. We are widely known, I don't mean to be arrogant, as the leader in low-level laser globally. We started in 1996, and we got our first US FDA market clearance in 2002 for neck and shoulder pain. And for those of you who don't really know too much about the US FDA, to promote a technology in the US market, you've got to go through quite a stringent experience of proving not just the safety of your equipment, but also the efficacy as well, which unfortunately has been one of the issues we've had in Europe for quite a while now. It's sort of been so under-regulated that to get a CE marking to be able to launch a technology or launch a product, you only really had to prove it was safe. So unless doctors or practitioners know what they're looking for from a clinical study perspective, it's very difficult to know whether what you are being told does what it says on the tin. So, the reason why we as a company spend over $1 million on every placebo-controlled, double-blind, randomized, multi-center clinical study is because we want to reassure our customers and their customers that it has been tested more than any other technology on the market for not just safety, but also efficacy as well. So low-level laser as a category or as an umbrella encapsulates a non-thermal laser diode, which is what Erchonia is, and also the likes of infrared and LED. Now, LED is important to us because we actually use LED as the sham, as the placebo to our studies. And the reason why it's very good to use LED against non-thermal laser diode is non-thermal laser diode, for one, is coherent, it's collimated, and it's monochromatic. So when we're delivering energy from the laser into, for example, at the front of my hand, even though you can only see the laser beam on the front, the energy is passing all the way through. And with an LED being a non-coherent light, as soon as the light hits the skin, the energy scatters. So by the time the energy gets to the mitochondria of the cell, which is what we all want, you've lost a lot en route. But it's very good from our perspective to include within the placebo-controlled studies. And being double-blind, the doctor and the patient don't know whether they're getting a non-thermal laser diode treatment or they're getting an LED treatment. It enables us to be able to gauge the results from both technologies at the end of the study, which is it reassures our doctors and our practitioners, and obviously your patients are spending hard-earned money coming to you for a solution, and I think it gives you the reassurance that you're providing them with the best solution on the market. There's 23 US FDA market clearances given to low-level laser, and we have 20 of them. So we're talking about, we've done 3 different neck and shoulder studies now, one with the red light, one with red and violet, and one with violet and green. We've also got clearances in chronic plantar fasciitis, lower back pain, nociceptive musculoskeletal pain, and also post-operative care. And obviously, you know, with the post-operative care, it was great. That was our most recent one. So it just accelerates the whole healing process after patients, you know, have a surgical procedure. So everything happens on a cellular level. It's all biological, works just like the agonistic effect you would associate with a pharmaceutical drug, but without the side effects and adverse reactions. So hence, we're able to bring you some great speakers like Rob Silverman, like Trevor Berry, like Kurt Gare, Dan Murphy, and a lot of the main players, and now Dr. Satya, who, you know, along with Jake Cook in the UK and also Eric Rees, we're hoping to deliver as much education as we can. So anybody wants to purchase some equipment, at least they're doing it from the place of getting factual information rather than, you know, what they may be told by I'd say a good sales rep, but it's really a bad sales rep because they're leading people down the garden path. So I just wanted to cover a little bit about us and what we were about. But now, Dr. Satya, if you are ready, I'd love to pass it over to you now. So, just quickly before I do, sorry, just to let everybody know down the bottom right-hand side, if you have any questions, put them in type them in the box. I don't really want to disturb Dr. Satya's flow, so what we'll likely do is...
Simon, I'm going to disturb your flow right now and say, if there are questions that are relevant to what I'm talking about in the moment, please go ahead and interrupt me. It's totally fine. I know all of this. I'm here for all of you. So if there's something that needs clarifying, I'm happy to answer it in the moment. If there are questions that are not directly relevant, I'll take them at the end.
No problem. I'll take you back to my school years and I'll put my hand up like that so you can see me. Right, I'm going to take myself off now. Thanks again, and over to you.
Absolutely. Thanks so much, Simon. Yeah, it's interesting. You were talking about the regulatory differences between Europe and the US, and Europe requiring only looking at safety versus safety and efficacy. And I, coming from a strong family background, I'm the 7th chiropractor in my family, growing up with chiropractic, it was pretty straight chiropractic with my dad and not much in the way of technology or supplements. This is the conversation Simon and I, we were just having before going live. And so the supplements and the technology pieces that I have incorporated into my practice have absolutely come from a place of a lot of research and a lot of really understanding the mechanism behind, not just the research, but understanding how it works. And we, you know, in these tiny little webinars here, I don't have a ton of time to dive into those mechanisms of action, but I will just say that for myself personally as a clinician, it's something that I really appreciate about Erchonia, above and beyond any other laser company I've found, which is why I will only use these lasers, is the research priority. And I'm actually in talks with Erchonia US. We're looking at doing some additional research on the sympathetic dominance and laser. So they're always just at the forefront of caring about showing what this is doing and not just saying it's safe, but it's actually effective. So we went through a couple of studies. There's so many, a litany of studies out there, but we went through a few last time. For anybody that missed it, we did do part 1 last week, looking at sympathetic dominance, neurofascial integration, and laser therapy. And what we're going into today is the part 2, where we really dive into the clinical strategies and how we're going to address sympathetic dominance as well as dural fascial kinetic chain tension, both of which we discussed last week as being the primary roadblocks to having more consistently powerful results in our practices. So today, I'm just going to take you through a tiny handful of quick and simple objective measures that you can use, plus a couple of powerful therapeutic strategies that will help to alleviate adverse mechanical tension on the central nervous system and also reduce chronic sympathetic dominance. Ultimately, these can be very easily integrated into your practice to help restore autonomic balance and facilitate greater change receptivity in your patients so that their body and brain is more prepared for whatever other kind of therapeutic input you are doing. So let's dive in. we'll do just a little bit of a review of the normal stress response. Remember that this is adaptive, not dysfunctional, right? So if a tiger is attacking you, or you have to navigate traffic really quickly, right? There's times when it's appropriate to have this response. And when that happens, when the sympathetic nervous system is triggered into fight or flight, you have an increase of stress, fear, aggression, anxiety, depression. You're gonna have less logic, less short-term memory, less learning. Your brain says, I don't need to learn math or remember somebody's name I just met. But your emotional memory will be hyperactivated. Your sensory sensitivity is up. You're going to have more fatigue and difficulty sleeping because you don't want to sleep if your life is in danger. You're going to have a higher blood pressure, higher heart rate, higher blood cholesterol levels to make stress hormones from cholesterol. We're also going to see an inhibition of reproductive function, an inhibition of sex drive, because we don't want to bring babies into an unsafe world. And we will also see a deprioritization of digestion, because again, that's not important when you're fighting for your life. And lastly, and maybe most importantly, is cellular immunity is deprioritized. So that Th1 type of response, which is for viruses and cancer, those are considered long-term threats. And so the brain says, that's not as important. I need to put my focus on short-term threats. So you'll actually see an activation of the Th2, itchy, sneezy, wheezy, allergic type responses because those are more immediate. Of course, in contrast, parasympathetic nervous system, we often hear it called rest, digest. I like to call it rest, digest, and connect, because interesting fact is that when you're in the sympathetic nervous system dominance, your ability to understand another person's point of view, your compassion, is neurologically suppressed. Because if you're being compassionate for the tiger, you won't fight for your life. So it's really interesting to note that how much it'll affect your social engagement and relationships as well. Of course, the parasympathetic is meant to be our default baseline at rest, and that's where we're going to have optimum homeostatic function in balance throughout the physiological systems. This is also where the system is actually open and receptive to growth, to change, to our therapeutic input as providers. So the brain requires 3 things to survive and thrive. Glucose, you need to eat. Oxygen, you need to breathe. And proprioception, you need to move. It's actually so important, proprioception is so important for our brain function, that scientists have suggested that exercise might be more important for the brain than it is for your heart, lungs, or muscles. Not that it's not important for those things, of course, but that it's so crucial our brain has sufficient proprioception in order to function normally. Of course, nociception are the alarm signals that activate a sympathetic response and can come from a whole host of sources. So when we talk about stress, of course, emotional distress is one of the stressors, but total allostatic load, the total stressors that exist in my life, in your life, in our patients' lives, is going to come from a whole host of sources, including any kind of tissue injury, any emotional distress, chemical insults, and adverse mechanical tension and distortions in the biomechanics of the body. We did go over this slide last time. I'm just putting it up again because I really want you to automatically be able to recognize sympathetic atonia or sympathetic dominance when it walks into your office. Because when we see these symptoms, they're often listed out separately and often in the medical community treated separately and independent of one another. But if we can be the provider that can stand back, look at the gestalt of this human being in front of us and say, wow, they are having brain fog and more irritable and high blood pressure and insulin resistance and they're healing slowly and they're having fertility challenges, you know, multiple things on this list, I'm going to say, this is clues. This is clues that the system is in sympathetic dominance. Because I want you to think about, just for a moment, have you ever had a patient who came in and complained about 3 or 5 or 10 of these things, right? They seem like they're stuck in sympathetic atonia. They're stuck in sympathetic dominance. I have a brief story because a lot of chiropractic, even though you know, we talk about research, which is hugely important, but a lot of chiropractic early success or early growth came from stories. And so it's important for us to honor and recognize that stories are part of how we recognize what happens, especially as we try to catch up on research, right? Because research takes a lot of funding. It's important for us to look at case studies. It's important for us to recognize stories. So I'll share one with you right now that I'm thinking of around sympathetic atonia. This was early in practice, and I had a woman come to me in her mid-40s. She had neck pain and headaches. She also had a lot of these symptoms. She was having some difficulty concentrating at work. She was extremely fatigued, difficulty sleeping. She was experiencing depression. She had quite a bit of hormonal imbalance and was struggling with perimenopause. But what I did was, instead of saying, okay, let me address this neck pain or let me address this headache, I said, wow, this woman has the signs of being globally stuck in a fight or flight response, which means, as you see on this slide, ultimately, they're going to resist any kind of therapeutic input anyway. Like, I might adjust and they're bracing, or I can adjust, but then it snaps back and I'm just doing the same thing, right? And so when I see a patient like that, I'm going to start with proprioceptive feedback, with laser therapy, specifically targeted at helping to modulate that sympathetic parasympathetic balance. And after maybe 2 weeks of working with her just in this way, I wasn't even getting into the specific subluxations yet because they weren't accessible. She had too much bracing, right? Too much guarding. And so I was doing more proprioceptive and laser input. And she came in 2 weeks in, and this was, I think I was a few months into practice. So she comes in crying, and I'm like, oh my gosh, what happened? What's wrong? And something she hadn't told me is that she had been going through a pretty ugly divorce process with her husband for, I think it was 6 months or a year. It had been quite some time. And she came in and she was crying, and I said, what's wrong? She said, nothing's wrong. I just need to tell you that since I started coming in, my husband and I stopped fighting, and we decided to stay married, not to get divorced anymore. Now, of course, you know, that doesn't mean every marriage can be saved in this way, but I would like you to consider, if compassion is neurologically suppressed, if your anxiety, depression, aggression are upregulated, think about how this is affecting marriages, how this is affecting schoolyard bullying, how this is affecting depression and anxiety and mental health challenges, how this is affecting war, right? Like, if we're stuck in fight or flight, I know I'm speaking a little grandiose here, but I think it's really crucial for us to recognize, before we get into the nitty-gritty, really the broad scope and impact potentially of being able to bring down sympathetic dominance for our people. So, adverse mechanical tension. Here's a little bit more science, and then we'll get into those clinical applications. So when I talk about adverse mechanical tension, I didn't create this term. This exists in the literature, but just clarifying for you, we're looking at fascial adhesions. We're looking at tension in the dural fascial kinetic chain. We're looking at abnormal spinal curves, as well as joint restrictions. So any of these distortions in the normal mechanics of the body can create adverse mechanical tension on the spinal cord, on muscles, on fascia, on the different structures in the body, which will change the sympathetic and parasympathetics, which we'll get into in a moment. It's also going to put uneven wear and tear on the joints and can create compensatory subluxation patterns and other vulnerabilities to injury. It can also affect organ function directly because the organs are invested in fascia. And so just like pulling on the edge of a bed sheet, if you pull on fabric, the tension line goes across the system. So you can directly affect organ function, including the CNS, because of dural tension around the brain. The fascia needs to be able to glide smoothly. Okay, so when we have adverse mechanical tension in the system, it changes actually how we absorb and disperse force across the system. So this is a model of biotensegrity, which is basically that the rigid structures are not resting on each other, but are suspended in space by the continuous elastic, which is meaning the tensional integrity of the structure. In the body, the bones are the rigid structures, and the fascia, with all of the muscles invested in it, are the elastic that's maintaining that tensional integrity. So if I have some adhesion between some of the fascia, and then an external force comes in, it's much more likely to injure the system because we're no longer able to absorb and disperse that force evenly and come back to the shape. If that is not there, and an external force comes in, it distorts the system, but then it returns to center unharmed. So that is the goal. Today, though, we are going to really focus on tension in the dural fascial kinetic chain. When we have distortions in biomechanics, of course, that's going to lead to less of the normal proprioceptive feedback that's meant to go to the brain and an increase of nociceptive feedback, which of course ultimately is going to create an imbalance that leads to sympathetic atonia. So if you need clarification on any of those pieces, do go back and watch the recording from last week. And of course, when I teach my live full seminars in person, we dive much deeper into this. But how are we doing? Do we have any questions so far? Because I'm closing out that foundation piece.
No, nothing as yet, Satya.
Great. So this is an assessment that I learned from functional neurology, which is to look at the peripheral visual field. Now, when we are in a parasympathetic dominant state, we are meant to be able to see 180 degrees at rest. So that means if I put two thumbs out straight to the side, I should be able, with my peripheral vision, while looking here at you in the camera, to see both of my thumbs. Try it right now. I invite you. Put your arms out to the side and see, can you see both of your thumbs? Now, when I do this test, I'll have people put their arms out to the side. I stand right in front of them and I have them look at my nose. I'm going to watch their eyes and make sure their eyes don't look to the side to cheat, because sometimes they'll do that even unconsciously during this test. So that's your job, is to make sure that their eyes aren't turning and their head isn't turning, because sometimes they will even involuntarily turn their head. But what you're going to do is ask the person to put two thumbs up and then bring them back 10 degrees where they can't see them. I just say put them back where you can't see them. And then one hand at a time, I say bring that one hand forward until you can see your thumb. Now, not just a blob, but the actual thumb. And then I'm like, okay, while I watch and say, you need to watch only my nose this whole time. And then if they can see their thumb using the peripheral vision while looking at my nose, I say, cool, stay right there, freeze there, and then do the same thing on the other side. So I'm moving over just so you can see my hand, but of course the person wouldn't move. Then I'm gonna have them bring the other hand forward until they can see both thumbs clearly. Not as clear as if it's right in front of you, okay? It's never going to be that crystal clear, but they should be able to know that's a thumb, not just a blob of flesh, okay? And also, you're only ever going to compare this like from now as a pre and post adjustment or pre and post laser therapy or at this exam and the following exam. And so their own perception of this, I know it can get a little murky actually, but it's their own perception getting compared to their own perception. So we explain it as best we can and go from there, take the test. So I'm going to have them freeze. Now they've done both sides. Now they stay right there. And I'm going to take a goniometer, I'm going to go around to their side, and I'm going to measure with the goniometer pointing straight out horizontal from the top of the shoulder. And then I'm going to draw the second line from the thumbnail to the top of the shoulder. That way, if their elbow is bent, it won't matter, because the degree or the angle I'm measuring is a straight line from the thumb to the top of the shoulder, and then from the top of the shoulder straight sideways from their body. That is going to then be marked as, for example, negative 25 degrees, if it's 25 degrees forward from 180. So it might be negative 25 on the left, negative 15 on the right. This is how you're going to notate it. Of course, the 180 is normal, and anything less than that is indicating that the brain is in an elevated sympathetic state. Because of course, when we go from parasympathetic to sympathetic, our peripheral vision shrinks. The worst I've ever seen is I had somebody literally in here before they could see their thumbs. That was a very extreme case of sympathetic dominance. Now, it's not unusual, though, to have people in the 30 to 60 degree range. That's not uncommon. So you're going to take note of that. And I will say that if there's a difference between left and right, it can indicate a cortical hemisphere imbalance. That's beyond the scope of what we're doing today. But anything less than 180 is suggesting that they are in a sympathetic dominant state. One of my favorite ways of helping that sympathetic dominance is through laser, because it has such a direct influence on brain function. By using different frequency resonances, you can actually help the brain to entrain to a more calm state, as well as any low-level laser therapy in these ranges that Erchonia is using, which are very, very, very low level. This small level is actually not just necessary, but it's better than using more power. So we often think with all kinds of therapeutic input, oh, more is better. But if you've been in practice for any amount of time, you've probably come to realize that there are quite a few times when you actually need less. And that's not just for therapeutic input, but even for palpation, to be able to feel what's happening. That if you're pushing too hard, it might be hard to feel. And if you lighten up, you can feel it even better. So something with laser is that when we do just a small amount of input instead of a sledgehammer to the system, which may create resistance and damage, when we use a small amount, then it can actually create a more powerful shift. And that's especially important when you have somebody in sympathetic dominance who's resistant to therapeutic input. So that's one of the best things about the Erchonia laser specifically, is that they're super low level. They're also going to sort of jumpstart the mitochondrial batteries and help increase ATP production. So we see pretty significant improvement just using laser. And I've actually done some informal studies in my practice and in the seminars that I teach, where I collect data of measuring the peripheral visual field before and after using any one or combination of these settings that I have up on the screen. And we see on average a 40% improvement in the peripheral visual field immediately following the laser. Now, the way I'm choosing between these different settings, I will tend to use the general brain one. It says just general, but it's the brain setting. I'll tend to use that 4/9/33/60 most of the time, unless there's a history of PTSD or anxiety. The parasympathetic one I will use to help activate parasympathetics if the first setting, I usually do about 2 minutes and then I retest. If the first setting didn't change it as much as I would have hoped, then I might also try to activate the parasympathetic. The other one is that if there's trauma, especially emotional trauma, but also physical trauma, like if there was a whiplash, a head injury, I may use the tissue memory settings as well. If you do applied kinesiology, you can muscle test for the different settings by shining the laser and doing your muscle testing. But otherwise, you can do it for maybe a minute or 2 minutes, redo your peripheral visual field testing, try it again. Now, if I've gotten, 40%, 50% improvement, we're good. That's probably as much as you're going to get in one session most of the time using laser on the peripheral visual field. And it's really important that we don't overwhelm the system. Now, the lasers are extremely safe. They're non-thermal. It's not going to cause any damage, but of course, we know as clinicians that there is a maximum amount of input that somebody's system can take before it's not really being as useful. So we need to give the system time, of course, to integrate. The other thing that is extremely helpful is giving some proprioceptive feedback. Of course, spinal adjustments are the #1 way to do this because the spine has the majority of proprioceptive feedback to the brain happening anyway. So we need to make sure that all of the joints are moving normally, that they're all sending the proprioceptive feedback that they're meant to with normal movement, and that they're not sending nociceptive feedback. The way that you can supplement proprioception, though, are with these little squeeze hugs, which is basically that you're just going to take the palm of your hand, and it's kind of a wave-like motion. You're not using your fingertips at all, but you're providing broad, deep pressure. Go ahead and do this to yourself right now. Oh, it actually, oh, it just dropped my voice. I don't know if you noticed that, but it also slowed me down. Now, I didn't do that on purpose. It's because as soon as my brain gets some proprioceptive feedback, it brings down the sympathetics. Of course, I'm excited, I'm teaching, I get all buzzy. And so this immediately can help to regulate. It's pretty remarkable how fast this makes a change. I had a woman that I was taking care of for years who had chronic low back pain, and a lot of the chiropractic things I was doing with her worked really well, and it was definitely manageable, but she was a midwife, and she took one of my NeuroFascial integration classes that I teach for healthcare providers. I, of course, don't teach them the adjusting portions, but all of the fascial, NeuroFascial pieces. And she came in on the second day and said, oh, I had that back pain in the middle of the night that woke me up. And usually it keeps her up for an hour or so before she can get back to sleep. And she remembered the squeezes because she was in my class. And so she was actively reminded. So she's like, I tried doing some squeezes and I woke up in the morning. She fell asleep that fast because it helps to regulate your nervous system. So this is something that can be done. I mean, the arms are easy to reach, but it's a global response. So you can do it, especially on the feet, are really great in situations with trauma, because the feet, of course, are the second highest density of proprioceptors, and they're far from the head and neck, which means it often feels safer in somebody's system. So if you have somebody who's really braced, who's not letting you into their system, you could just do some of these gentle but deep squeezes in the feet and moving those joints around, feeding some proprioceptive feedback to the brain, calming the nervous system, and work your way up. So laser and proprioceptive input are both really good are really, really good pre and post adjustment as well, because they help prime the nervous system for input, and then they help it stay with the new input and feel safe with that change. Yes.
Hi, Satya. Yeah, 3 questions actually now come in. First one, how long do you laser for general, PTSD, anxiety, parasympathetic, and tissue memory? And do you recommend doing each lobe?
So I generally am moving it around for 2 minutes, and that's what I'll start with. Like on the first session, I do 2 minutes, I'm redoing my measures, and I see how much change I'm getting. Then I adjust, I see what additional change, I'm trying to get an improvement 60 to 90% on the first visit in the peripheral visual field between laser and then proprioception and then adjusting. If they do well with that 2 minutes, I might try more next time, because sometimes, but I do it in 2 minute increments. So I might do 2 minutes and then 2 more minutes. And I keep it moving. I know that there are also really convenient arms to hold the laser still on somebody's brain while you're adjusting, which can be very helpful. So if I do that, I set it back far enough so that it's actually crossing both lobes of the brain. I know that there are situations where yes, exactly, where it's appropriate. Yeah, I guess I could use my laser and show you guys. I know that there are situations where it can be helpful to stimulate one side versus the other. That's a little bit beyond the scope of what we're doing today. And I will say 90% of the time, I'm not getting that specific. I am just lasering both sides of the brain, and I'm actually lasering all around, just to give it that support. It's not, you're not going to hurt anything. And the laser in general is going to help jumpstart the mitochondrial production of ATP. And so that's useful everywhere. And then those settings like that are PTSD or parasympathetic, those settings are, I'm just going to get my laser going here so I can show you some stuff. Those settings are not going to force a change. Like if you need it on the left and you don't need it so much on the right, it's not going to hurt the right for it to be there. And that is much more expedient for me as a provider, knowing that it's perfectly safe and that I can be a little bit quicker with what I'm doing and not ask the patient to go through so many tests every time also. So I will just show you this is how I'm generally doing it, is I'm holding it horizontal and moving it around the head. Yeah.
The simple thing we always say is just like brushing your hair.
Yeah. Yeah, I mean, I'm trying to make sure that the brain is getting the impact of the laser. Now, like I said, I know that there are, especially in functional neurology, like there are schools of thought that get more specific. I have nothing against that. I generally don't find that level of specificity necessary when I'm sort of washing the brain in the frequency that I'm trying to do. I will also point out that the PTSD, the anxiety, the tissue memory, and the parasympathetic can also be useful in other parts of the body, which of course is going to affect the brain through the whole nervous system. So if they've had, for example, a sexual assault, I will probably laser this part of their body. If they've had a skiing injury and busted up their knee, I might do tissue memory on the knee, especially if it's a chronic old injury that should have resolved by now, but maybe they keep injuring it. I had a patient recently like this, who was scheduled to go in for knee surgery because he just, over the past 20 years, keeps injuring his knee. We did some laser with tissue memory and with anxiety and PTSD based on muscle testing using applied kinesiology. And that was able to allow more manual therapy to the knee, which it couldn't tolerate before, which then allowed him to recover. So, you know, I know people always want to say, well, what's the exact amount of time? And I say, well, start with 2 minutes and go from there and use your measures, because this is why I'm teaching, you know, I gave you at least one objective measure, because we need our exams to be the thing that dictates our care. It can't be just the same protocol for everybody. It's never going to be the same. Every once in a while, I'll say the person is clearly full of input, like they get more buzzy feeling, or they're just like squirmy after a minute. And I'm like, okay, that's fine. We'll be done after a minute today. So sometimes it's less, but 2 minutes is a really good average starting point. And I wouldn't do more than probably 8 minutes in total. I don't think that it's problematic. I just haven't seen somebody need more than that, even in more severe cases. And when I say 8 minutes, I mean combined. Like I might end up doing a couple different, I might do a couple minutes of PTSD and then a couple minutes of tissue memory on the brain, for example, while I'm adjusting them. So that's a clinical artistry thing that I can give you my thinking and my guidelines.
You've already answered the next one, which is where on the brain do you laser? I think there's a few dictation errors here. Do you treat the naked skin?
You know, what, you've got hair, you're gonna make them shave their head? So yes, no. I mean, if their skin's exposed, yeah, it's fine. I don't make them expose their skin. I have been told, and it makes sense to me, that lasering through dark fabric is more effective than lasering through light fabric. But I have never seen somebody not respond just because they were wearing a white shirt and I lasered through it. I mean, the lasers are designed to penetrate, and I think that the loss of energy through fabric is probably very small.
Yeah, we normally say one item of clothing, but when the patient is obviously in the clinic, there's never usually an issue with them actually, you know, derobing.
Yeah, I mean, if you're in a full like jumper and coat, yeah, take it off. But like if they're wearing a shirt and pants, I think it's fine.
Yeah. The last one before we let you move on there, it's a little bit more generic, but it'd be interesting to know your feedback, because this lady's asking what are the contraindications for the laser. Now, that can be split up into two ways. Whenever we do clinical research into something, we don't class them specifically as contraindications. We just choose to not include a specific group within the criteria. For example, we would never include pregnant women. We would never include women who are breastfeeding. We would never include somebody who has active cancer or has photosensitive epilepsy. But there are certain things that I think that the doctors say in the real world, it's sort of treat with caution on certain things. But we would sort of say the generics there, Satya, are, you know, the pregnant women breastfeeding, pacemaker, active cancer, photosensitive epilepsy. But sort of common sense with some of them. Is there anything else that you would incorporate in your clinic? Because predominantly it's down to you as the doctor, because visible light does no harm, you know. So
I mean, the thing is we don't have data showing danger for those scenarios, but we also don't have enough data showing that it's good. And so we really, like you're saying, do have to lean into our clinical judgment. I would start with far from the site. Like if somebody's a pacemaker and I'm trying to put the laser on their foot, it's probably not that big of a deal, you know. But that is something that you're going to have to use your best judgment. I don't have any. Let me think of contraindications. I mean, because this is a non-thermal laser, there are other lasers out there that I would definitely not. I would be worried about burns. I'd be worried about epilepsy. There's things I would be worried about. With this, I'm not. I have used this on people with seizure disorders with no problems. Of course, I have their eyes closed or they're face down, like they're, you know, I know there's sunglasses you can have people wear, but I just have them close their eyes. And I don't shine it in their eyes. So if somebody's photosensitive, I'm not showing them flashes, right? I have used this with young children. I generally will use less time. If I'm concerned about an individual, I might do a 30-second trial, right? And see how they go and measure how their nervous system's responding. Because if we have a measure of neurological distress, like the peripheral visual field is 1, then you can see if the nervous system is experiencing distress, right? And if you do applied kinesiology and can do the muscle testing, the sensory motor functional muscle testing, even better, because you can challenge the system immediately and see if it's creating an alarm reaction, or using leg length inequality testing, right? Like there's tests that we can do. And I think this, you know, this is an important discussion of our capacity as clinicians to not just follow a protocol, but because we don't have sufficient information, right? We have a growing technology. This is the way it is. And what are we going to do? Wait 40 years and not help the people that could be helped now? No, but I am going to be judicious in using my tools of measurement to assess whether the system can handle that kind of input. And I say can handle because when I was like it was pretty soon after a really severe car accident I had extreme sensitivity. I had to wear earplugs 24 hours a day, even to sleep, because my voice in a whisper was loud enough, like to, you know, if you hear a loud bang, like fireworks or something, it startles you. I would get startled in my voice in a whisper myself. So it was extreme hypersensitivity and neurological damage from this car accident, and tried using a laser on my brainstem and I fell down. Now, I didn't get hurt. I mean, I didn't even get hurt from the fall because it was a very slow fall, but it was just too much stimulation for my nervous system. And, you know, so I started actually with just like a pen light laser for a few months, and then I graduated back up to the accelerate, the red laser. But the red laser is a really good place to go with more sensitive individuals, because usually, you know, I haven't had anybody else actually with that level of sensitivity, but the red laser alone, which is the accelerate, is really nice because it's super low power. And because of its frequency, it has a very small amount of power per photon going in. So that's your like entry level. And then the EVRL and the green and the violet both have more energy per photon coming in, so they can be more effective, more efficient. But if you're concerned about a sensitive individual, I would start with the red and then graduate them up to the green and then to the violet.
Cool. There's other questions, but I think, you know, we'll save them till the end. They're more generic.
So dural fascial kinetic chain tension and sympathetic atonia. Of course, when we have changes in the proprioceptive and nociceptive feedback because there's tension in a system that should have slack, then you will see more alarm happen in the brain. I wanted to give a mention to tethered cord syndrome because that is a diagnosis that sometimes people will come in with, especially children. And surgeons like to cut part of the dura, the filum terminale. They like to go in and surgically alter when there's really high cord tension. And because I recognize that the dural fascial kinetic chain is all interconnected, we could work on the fascia in the lower legs and feed the length upward, alleviating some of the tension in the spinal cord. And that would be a much, obviously, non-invasive, not less, but non-invasive and much safer thing to try first before surgical options. I will point out that when the resting tension of the spinal cord is higher than it's meant to be, just like a guitar string that's too taut, it is going to actually change the electrical conductivity across the spinal cord. So because the spinal cord attaches into the dura, attaches to the tailbone, and then of course through the sacrotuberous ligament goes into the lower posterior and lateral fascial lines into the plantar fascia. If that was too fast for you, go back to the slide on our last week's recording, because there is a picture of the whole DFKC. But it's changing the electrical conductivity across the system. The other piece that I just want to throw out there, because that's what I keep doing, is giving you little nuggets that I just want to include, is that there's some really interesting research around the glial tensegrity. So the glia, the support cells in the nervous system, the central nervous system, the microtubules inside have that tensegrity structure. So I talked about the bones with the fascia, but also right down on a cellular level, fractally at all points of zooming in and zooming out, we actually are tensegrity structures where the elastic is what is maintaining the tensional integrity of the system. So in the microtubules of the glia, they actually have a vibration that gets shut down when we are put under with anesthesia. And the theorizing that is happening around this is that perhaps that vibration is actually what is allowing our physical body to conduct the raw proto-consciousness of the universe, which you could call God, you could, this is like the science terms, the religious terms, but it's this really fascinating conversation, I'm not sorry for that, around the vibrational tuning that exists in the tensegrity system, so from the microtubules all the way out to the fascia, because it's all interconnected, that when we have changes and distortions in the global tensegrity of the body, it may actually be affecting right down to the microtubules and the glia, and may affect our capacity to conduct consciousness in the body. So there's a can of worms that we're not going to talk about anymore, but it's just these pieces. I think it's really interesting for us to recognize how far-reaching and how global the impacts are of this work, of not just saying, yeah, there's spinal cord tension, they have tethered cord syndrome, but actually saying, how is this changing our perception of reality, our experience of reality? So a very easy way to assess dural-fascial kinetic chain tension is a modification of a test you probably already know, which is Soto Hall, which can of course be done standing or seated. I'm doing it seated here. And what you're going to do is you're going to have the patient sit with their legs straight out in front of them and make sure that their knees are not bent. And then I'm going to ask them to keep their low back straight first and curl, like hinge their body forward, and then they can drop into curling. And then I want to look at, I'm going to take a measurement. I'm going to take the tangent at L1, right, from the vertical, and measure how much flexion they have there. That's just a standard test. But then what I'm going to do is compare and say, okay, if they point their toes, if they plantar flex versus dorsiflex, does that change the measurement? If they go into cervical extension versus cervical flexion, does it change the measurement? Because all of these things are challenging the dural fascial kinetic chain, of course, that's going to run all the way from the dura, through the spine, down through the back of the legs, through the bottom of the feet. So when we make changes throughout the system and we see, for example, if they plantar flex, now they can go further, well, we just put slack into the DFKC by allowing them to plantar flex, which is what allowed them to go further. If we allow them to go into cervical extension and they go further, again, that is putting slack into the DFKC. Whereas if the neck is fully flexed, the spine is fully flexed, the knees are straight, and the feet are dorsiflexed, that is like maximum DFKC tension. So you're gonna see a reduction in that L1 measurement that's going forward from center. So this is a pretty easy way to tell, is there tension in the DFKC? And if you weren't here last time, you're in luck. Actually, there's a picture again so that you can just see what the DFKC looks like. I'm a better doctor than artist, but hopefully I got the job done there. The reason I did the drawing is because I'm actually the first person to publish research about the DFKC. So I made that nice little picture a couple of years ago. Anyway, so adjusting in the dural fascial kinetic chain, this is just something to recognize that, of course, there are going to be joint structures that are going to influence DFKC tension. So you can have fascial tension, but especially in that lower line, but also in the rib cage. But you can also have subluxations in the spine, especially near where there are dural attachments that are necessarily going to influence DFKC tension. So anything cranial, because the dura is sort of glued to the inside of the skull, right? It's contiguous with the periosteum. So if you have cranial imbalances, that's going to affect DFKC tension directly. Any upper cervical subluxations in the occiput C1, C2, again, because of dural attachments there. Now, there aren't many attachments in the spine itself, like between the upper cervical spine down to the bottom. But what we do have is that the nerve root sleeves, the epineurium, is contiguous with the dura and contiguous with the fascia around, like the ribcage fascia. So there are some of those connections, but the reason that I put upper and mid-thoracic anteriority is because if we have a loss of the cervical curve, right, because of forward head posture, and then the brain says, well, I want my eyes level on the horizon, so the brain will reactively straighten the thoracic curve. Now it's too straight, okay? Now you're going to have a spinal cord stretched straight, so you have more cord tension, and your brain says, well, that's not good. And so it makes muscle tension between the shoulder blades, which you see people with like chronic muscle tension there, and they get a massage, it might feel good, and it goes right back because the muscles are tight because they're trying to help alleviate the tension on the spinal cord. But the other thing that happens is when the spine's too straight, you're vulnerable to getting an anterior subluxation in that lack of thoracic kyphosis that should be there, right? So we may need to adjust that anteriority out to put some slack. Now, ultimately, if somebody has got straightened spinal curves, then that's going to need curve correction over time. The other subluxations that are pretty common with DFKC tension is an anteriority at L5. Logan basic can be a really helpful technique because it addresses tension through the spinal cord and the entire spine through the sacrotuberous ligament, which of course is a central part of the DFKC, as well as tailbone subluxations, coccyx, because it is the great modulator that is attached to the spinal cord as well as the lower lines of fascia. And if it can't move around and modulate cord tension when you change position, then you're going to have more nociceptive input constantly going to the brain because of tension imbalances. Now, laser is going to be able to give us a direct influence on brain function through the neurological pieces that we talked about, but also by affecting the fascia and actually changing DFKC tension by releasing adhesions. So the two places that I'm using the laser the most for DFKC tension are going to be directly in the sacrotuberous ligaments if I'm seeing ligament tension there, which you can palpate for. You can do prone knee flexion tests out of Logan Basic. But if I'm seeing tension in the sacrotuberous ligaments, I will use the ligament settings for a couple of minutes on the side of tension. If they both feel tense, then I'll do both sides, or I'll just do the laser so that the beam is crossing both sides of the sacrotuberous ligaments. The other place you can do it is looking at the intramuscular fascia of the calves. Now, I don't know about what happens over in Europe, but over here, my grandma taught me that this part of the body is called the Hello Betty, because when you wave Hello Betty, it waves. Now, the point being of that silly story is that the body is supposed to be supple. It's supposed to move. I had a patient, a professional modern dancer, who she came in, and when she would sit on her knees, like with her heels under her butt, she stayed up pretty high, like her calves didn't really squish when she did that. And I looked at them and I was like, wow, they're pretty solid. And there was a lot of adhesions in the intramuscular fascia. So I needed to go in there and break up the gunk. And I can do it with my hands, but she's very strong and that's tiring. And so I did it with my laser using the inflammation setting, which helps to lower inflammation through IL-10 and some other pathways. So that setting, I did 2 minutes on each side and then rechecked, and she had more supple movement in that chunk of muscle in her calves. And when she was able to sit on her knees, her calves actually splayed. And it was fascinating because she said, oh, I had no idea. I thought that my calves were just like that because I'm so strong. But she actually gained more power once we had them more supple and more able to be flippy flappy around. Because of course, more parts of the muscle are able to engage when they're not all glued together. Like we have different fascicles, we have different bits of muscle. It's not one solid thing, it's a bunch of bits all working in concert. And if they're glued together, they can't do that as well. So those are the places that I use laser for the DFKC. Of course, thinking about the impact and relevance, when we have people with signs and symptoms of sympathetic atonia or sympathetic dominance, same, or if we have just difficult patients, like people who maybe we didn't recognize that they have sympathetic dominance, but they're just not responding how we'd expect, right? Maybe you're making progress and it always snaps back. Maybe they're just bracing a lot. There's a lot of resistance. That's a great time to say, well, let's try using some laser therapy on the brain, on the body, to bring down that fight or flight response. You know, of course, checking our peripheral visual field. Let's check the DFKC. Let's see if there's a lot of tension. Let's use some proprioceptive feedback. Let's loosen up fascial adhesions. Now, I will say, loosening up fascial adhesions, if you're going to do manual therapy, it's really important, especially in cases of sympathetic dominance, that you don't go in and do something too aggressive, like Graston or a lot of these kinds of neuromuscular reeducation, ART. A lot of them are very, very intense and can have the opposite effect we want, which is that they will actually trigger the body to go, oh, that was an unsafe change, and it's going to want to snap back. So it's really important that we're modulating the autonomic nervous system and making sure that they are experiencing safety psychologically, emotionally, but also neurologically and physiologically in order to make sure that our work is going to snowball in the right direction as opposed to go against what our efforts are because we're freaking out the nervous system. Also, patients with cerebellar tonsillar ectopia, which is the brain injury that I have. It's a herniation of the lower part of the brain through the brainstem, or through the foramen magnum. And I will just say briefly that 1 in 20 people with neck pain have some degree of brain herniation, 1 in 20, and 1 in 4 people with neck pain and 1 history of whiplash or concussion. It goes up to 1 in 4 if you've had 1 head injury, 1 concussion, 1 whiplash, have some degree of brain herniation. You need an upright MRI to see it. That is, I have a whole class actually on the diagnosis and management of CTE because it's so extremely common. But if you have somebody with this, then both DFKC tension and sympathetic dominance are very relevant for those people. And because there's so much defensiveness in the system, laser is extremely helpful because you can start without touching them. Of course, I talked about forward head posture and loss of cervical curve. Just some brief notes I wanted to say about incorporating laser into my practice. Because it's such a fast and non-invasive way to access the nervous system, it's a good thing I can combine with proprioception in order to provide a container in which I provide the chiropractic care, in which I provide the adjustments and whatever other kinds of therapeutic input I'm trying to do because of how it helps to facilitate change receptivity. being able to access the nervous system is especially important in cases of tactile hypersensitivity, sensory processing disorder, autism, PTSD, trauma, injuries, etc. You can combine using the laser while they're doing different exercises, whether those are brain exercises or physical exercises. You can also get the stand and laser them while you're adjusting. That's really ideal to have that stand that you can get from Erchonia. My favorite thing, I guess, that I want to point out about these things is I'm always trying to figure out how can I reduce my level of effort and my energetic output so that I can see more patients or still have energy at the end of the day to go have fun, be with my family, all of these things, because our capacity to take care of people, our capacity to have a career and fulfill our sense of purpose depends on our longevity, depends on our quality of life, and anything that can help make it easier for us to see more people and last longer in this career, I think is really important. So briefly, the way that I'm incorporating it just on a logistical level, you can either do the FFM as fascial flow method, which is my proprioceptive and fascial feedback technique. So you can either do laser and fascial flow or whatever kind of fascial work you're doing adjunct, just like any other manual therapy, and just charge it itemized if that's how you run your practice. I do mostly outcomes-based care packages, and so I will roll everything together, so you can do that as well. Or you can also rent the laser out on a weekly or monthly basis, and that's a really powerful way. That's why I like having a couple of lasers, actually, because some people, they don't need to be coming in to get adjusted 3 times a week, but it would really help them to have laser several times a week. And so that's probably my favorite way, actually, to do it, because then, 1, there's less time on my part, and 2, they're more engaged in their care, so they feel more agency, and anything that we can do to give somebody more agency over their health is, in my book, the way. So I will leave you with this poem that I always close every talk and seminar I do with. I shared last time, I'm going to share it again now. I stand on the sacrifices of a million women before me, thinking, what can I do to make this mountain taller so the women after me can see farther? Of course, I include everybody in this. The poet was speaking about women, but I include everyone. I appreciate you all so much and your dedication to your professional excellence, being here today with me this evening, afternoon, wherever you are in the world. I'm delighted to connect with any of you on Instagram or Facebook and continue our collaboration. Feel free to email me with any questions. Here's my contact. And I definitely just want to thank Erchonia, because your commitment, and Simon, you're getting to hear, you're all of Erchonia right now, but Erchonia's commitment to research-backed laser science is really at the forefront of clinical knowledge. And the way that Erchonia has harnessed the power of energy healing in a reproducible, tangible way that not only makes our jobs easier professionally, but has helped me personally beyond measure. So I'm honored to share Healing Community with you all. Thank you so much.
No, thanks for that, Satya. There's quite a few questions come in.
All right, I think let's do it.
What you've just presented, fantastic. We always try to, as much as we can, present neutral information, and that's a lot of the education we're doing in Europe, because there's so many gray areas. We've come across certain technologies where our data is on their websites, and it all boils down to, doing the necessary levels of due diligence when you're going to use your hard-earned money to invest in your practice. So, take a little bit of time to have a look at the studies. If a certain manufacturer or a certain technology are saying something specific, ask to see written proof of it. If you need any help, digesting it or understanding it, we're always here to help. And whatever anybody goes for, it's completely up to them. We just try to deliver the facts across the board. So
well, and that's why I tried to give you guys a couple of objective measures. I mean, I know I could only do 2 little ones. This is such a short thing, but that's always at the forefront of any time I'm teaching, is how are you going to measure it? Because you can't just take some protocol, especially from a company, but from anybody. Like, our patients aren't cookie cutters, right? And that's where our poweralizing as clinicians is our capacity to evaluate the different options that are out there and say, how am I going to incorporate this in a way that I know? How am I going to know that this is working? Not just that it makes sense, which it has to make sense. You start with that, and then say, how am I going to measure it? And so that's, you know, that's what I've hoped to share some of with you today.
Definitely have, for sure. This question is from Mia over in Sweden. She has one of the EVRLs. I do a lot of work with clients with mental problems. The results are amazing. Is there any studies for XPTDS that are published? Do you have any recommendations? Thank you for a great webinar. Love it. I mean, I don't know if you know anything, Satya, but Mia, you've got my email address. If you want to email me, and we can have a look on PubMed and send you something back.
That's what I was going to say. I mean, every time I want to study on something, I just email Erchonia and you guys come back. I mean, I also do a lot of PubMed lit searches myself, but I will say that I'm happy to share any literature that I do have, but I think that the best place to get your guys' questions about specific conditions would be to connect directly with Erchonia, because they can help you with whatever litany of literature exists.
Yeah, we have those little links into the regulatory department, so we can, what would probably take me an hour to find on PubMed, Travis can normally find within a couple of minutes.
Right. So. Yeah, you're much faster.
Darren, is there a specific laser you mentioned today? I have the Erchonia FX and would like to know if I can use it the same as the handheld lasers. Yes, you say that you can use both.
Yes.
The beauty of the FX is obviously it's an unmanned treatment. So the patients, you program the laser, the FX to everybody else just positions over the head, and you just choose whichever frequency, whichever setting we're going to go with, and then press start and off you go. But we do have some stands for the handhelds as well, which will just sort of slot in. Unlike the FX, which the laser beams rotate around.
I love the FX because it does the movement hands-free, so I don't need to do that. I mean, what I am holding right here and that I use personally on myself is the EVRL, because I travel and I can't be bringing the FX with me everywhere, but I do have to sit here and move it all around. But the FX is a great option, and yes, you definitely can use these settings with that.
Yeah, I've traveled a lot around Europe and the Middle East, and I take it with me wherever I go. I try to sort of laser my brain, my vagus nerve, and my nerve root every day, just for a few minutes. But there's only one place I've ever been stopped with it, because they said, "What is it?" It was in the early days, and I said, "Oh, it's a laser." And I think they thought it was something like out of James Bond. I was going to sort of chop the pilot's head off or something. Yeah, they're looking
for the sharks. I know.
which is the lack of understanding as to. With laser, the lower you go down in wavelength, you deliver no heat, but you deliver, photonic energy. And they didn't know that. They made me put it in my luggage, but that's the only one. I think I must have gone through maybe 100 different airports probably with this. But as you said, it's portable, it's easy to travel. And if I ever fall out with my co-directors, I'm going to be running as fast as I can down the street with it, and I'm not going to give it back. So. Okay, this is awesome presentation, Dr. Satya. As a veterinarian and fellow Erchonia presenter, decreasing sympathetic tone for parasympathetic predominance is key to enhancing healing. From calming anxieties to allow consent, to increasing appetite, intestinal motility, and immune response. Thank you for this. And that's from Janet, who we know well from the veterinary side. Mia, again, can you please tell us how do you, the words are quite mixed up. I think she's saying, how do you use it on a trauma treatment? Can you please tell us how you do when you do a trauma treatment?
Well, trauma is a huge word. I mean, maybe you could be a little bit more specific in your question.
Actually, Mia, just send me, when you send me an email regarding the publication, if you just include it on that email, and we look into it in a little more.
Yeah, I'm happy to break that down a little bit more. But I mean, I'm not doing the exact same thing across the board. So it would depend what kind of trauma. Like, are you talking about a skiing accident? Are you talking about like divorce in the family? Like, what kind of trauma are we talking about? That's definitely going to affect how I handle the patient.
You can elaborate that with me. Now, Darren, I'm not sure whether he's in the US or actually across this side of the pond, but The way we do things in Europe is a bit different when it comes to the frequencies, such as you do in the US. You know, Erchonia have been going since 1996 across there. They've got over 17,000 laser users. So that you guys are more at an advanced level as we are across here. So myself and Rob Silverman came up with a more simplistic way of doing things. We pre-program a lot of the frequencies into the laser. We group them, so we have acute 1, 2, 3, subacute 1, 2, 3, wellness performance 1, 2, 3, gut, brain, chronic, and nerve root. So we try to keep it as simple as possible across here, because what we were finding was we promote a lot of the US webinars, and because a lot of our US peers are a lot more experienced, they go a lot more into the frequencies. But just to be clear, when it comes to the lasers, around 85% of the result is specific to the wavelength. The extra 15%, I suppose you could say, is the cherry on top of the cake. So if we're going to do acute, we would treat the majority of things with that, as long as it's within the first 5 days of the injury happening, or the illness or the disease or whatever it is. And then subacute 1, 2, 3 we would do until we'd actually created a positive result. Going forward, to try to provide like a prehab type thing, we've set it up as wellness and performance 1, 2, 3, and of course chronic speaks for itself and what have you. So this is why I don't know where Darren's coming from. What frequencies are you using for sympathetic issues? So you can answer from your side on there, Satya.
I mean, I can answer that pretty easily though. So I mean, the red violet combined is what we've seen in research works the best to help modulate sympathetic dominance. And just as Simon was saying, the fact of the wavelengths of those light actually, so the frequency is like the Morse code, right? It's the pattern of burst, like flashing the light on and off basically. And that will affect, through resonant frequencies, that is going to entrain the nervous system and or any tissues to that frequency, which can be very helpful. But just the fact of using the red light and the violet light combined, that's going to help bring down sympathetics. But that parasympathetic and also the PTSD setting and the tissue memory setting and the anxiety setting, all of those that I put in there, any of those are additionally to the red and to the violet light those frequencies are going to, as Simon said, be the cherry on top, be like that last 15% that really dials in, giving a better shift into parasympathetic. So EVRL in general brings down the sympathetics, the parasympathetic activates parasympathetic, and those others are helping with PTSD or helping with anxiety or helping with tissue memory. And so that's something that you can get more granular with in your treatment, but you could just stick with the brain setting. By using an EVRL with the general brain setting, you are going to bring down sympathetics and help activate parasympathetic.
See, all these frequencies we pre-program.
I do too. I have them pre-programmed. I just have like PTSD, anxiety. I just set them as settings in my system.
One of the point I was making was for anybody who's new to using the lasers, we pre-program all of these settings in before they receive it.
When they purchase it, it's already in there.
Yeah, exactly. Yep, and of course, if there's areas that they specialize in, Rob Silverman does a lot of the training via video training online from his with patients with the FX or with the EVRL. So we discuss it in more depth there, but when we're talking about, as I'm sure you've covered, parasympathetic and sympathetic, that's why the EVRL or the FX405 combining the violet with the red light, you're able to target both. Whereas if it's just the red, as Satya said, it's different. So I think that's it, guys. So unless you have any more questions, I will let everybody go and get their dinner.
Okay, perfect.
No, thanks so much again. You've been a refreshing change from the webinars we do, and we look forward to inviting you over in person so we can get you doing some hands-on stuff.
Yeah, we can do so much hands-on. We're in person, so let's do that.
One of our good clients, Julie in London, please, it would be great to have Satya over here. So we look forward, and as soon as we get something dialed in, we will let everybody know. everybody who I think's tuned in here should be on our database that we send invites out to every time we do a webinar or when we do seminars. So yeah, you receive your invite. So Satya, thanks very much again. That's hugely appreciated. And we look forward to meeting you in person and to the next webinar session that we do with you as well.
Absolutely. Have a great night, everyone.
Cheers, Satya. Take care.
Take care.
Bye-bye.
Bye-bye.